So another group of drugs that are, really clinically important are these azoles. And these can be further subdivided into different chemical classes, but they both work the same. And so they're going to inhibit linosterol demethylase, and this is a fungal enzyme that's really needed for the synthesis of ergosterol. And then by way of altering ergosterol synthesis, we're going to reduce the structural integrity of the fungal cell membrane. And so, as I said, there's two different chemical distinctions, the imidazoles and the triazoles, and we'll talk about the differences of those in a minute. The main clinically relevant side effect is really a non-specific side effect that comes about through hepatic biotransformation. And so the azoles are really well-known CYP biotransforming enzyme altering compounds, and so there's tons of drug-drug interactions with the azole family of compounds. And so again, these are mediated through the CYP cytochrome P450 system. So the first group we'll talk about, we'll discuss the imidazoles, and the prototype here is ketoconazole. Ketoconazole is formulated for either oral or topical use, but if it is orally administered, the absorption is going to be pH dependent. And so patients that have alterations in stomach acid will see actual various clinical outcomes based on how much of this drug was absorbed. And so to that effect, drugs that change the stomach acid, proton pump inhibitors, H2 blockers, the over-the-counter Tums, and some other drugs can actually change the clinical benefits of this drug dramatically. The toxicity is associated with minimal toxicities such as nausea and vomiting, but also some other potent toxicities which are listed here. And this comes about through the ketoconazole effect, specifically on inhibition of mammalian androgen synthesis. And so it's going to mess with hormone production. So gynecomastia, oligospermia, impotence, menstrual irregularities, alopecia, all of these and others are really associated with prolonged and or regular use of ketoconazole. And it's also a common cause of drug-induced diabetes. And so even though the toxicity profile is quite long, and in some cases problematic or troublesome, a lot of patients don't really go on ketoconazole for that long. I mean, you're really looking at giving, 4 to maybe 7, 8 days of this drug for a specific fungal infection, and then you may never ever prescribe that drug to that patient again. And so what are those fungal infections? Well, you can see them used for both tinea and candida skin infections, and that's pretty much it. So if patients get some of these types of skin infections, they'll go on ketoconazole for maybe not even a week, and this side effect profile doesn't really happen. But it's only when patients are on kind of prolonged or regular use of ketoconazole for persistent infections. So what do those drug interactions mean? Well, remember that ketoconazole is a CYP inhibitor. It's going to inhibit the metabolism of, and it's going to increase the levels of specifically cyclosporine, tacrolimus, warfarin, rifampin, and phenytoin. I know we haven't talked about all these drugs. Rifampin and phenytoin specifically are CYP inducers and will likewise actually reduce ketoconazole levels. And so there is a inhibitory effect as well as with some of these drugs that are listed here. And don't worry if a lot of this mechanistic stuff in terms of these drug interactions don't make sense at this point. We'll develop this throughout the curriculum, and so we'll show you how you can predict some of these clinical effects. So the other group of drugs are the triazoles, and the prototype here is fluconazole, but also itraconazole, voriconazole, posaconazole. Those are all triazole type azoles. So we'll start with fluconazole. Fluconazole is formulated for either oral or IV use, and the oral absorption is actually pretty good. It's 95% bioavailability, which is almost unheard of in terms of orally administered drugs. So they're usually not that high. Remember, IV administered bioavailability is always 100%. So this is 95% through the oral dose, and that's quite high. This drug has a large volume of distribution. It has good penetrance into the central nervous system. But ironically, it's also water soluble too. It's got a unique chemistry that has both hydrophilic and hydrophobic components to the molecule. This drug is renally eliminated, of course, and it's got a long half-life, so we can use once daily dosing. The toxicity includes alopecia over the long-term use, and again, kind of this rare but importantly clinically relevant drug-induced hepatitis. Fluconazole is indicated as probably the most often drug out there to treat the various candida infections. Also, it's been useful for cryptococcus, coccidioides, including meningitis because it's got good CSF penetration. It really has no activity against molds. We'll talk about which drugs can be used for something like aspergillus. Let's look at a flashback here. So remember we had talked about ketoconazole and some of these other drugs. We had mentioned specifically in these in the asthma lecture when we had first talked about inhaled corticosteroids, and we said that there's kind of a unique side effect in terms of the production of thrush. And so we said in order to prevent thrush or oophoringeal candidiasis in patients that were taking inhaled corticosteroids, we can tell the patient to gargle water and spit after the steroid's been inhaled. And so sometimes they forget to do that, or even if they do it, they can still get thrush. And of course, the treatment for that is a topical antifungal, such as nystatin, which we'll talk about, or amphotericin B, which we've already talked about, or a systemic oral azole, such as fluconazole or itraconazole. And so just to kind of go back and review some of the pharmacology we had learned, here was an example of a one drug causing another illness, and then here's another group of drugs to treat that illness accordingly. So let's continue with our azoles. Let's go to itraconazole. Itraconazole has been formulated only for oral administration, so that's the part that's unique about this particular drug. And the oral absorption, of course, is going to be similar to ketoconazole. That's going to be pH dependent. Okay. There is a suspension or a liquid oral administration of this particular drug that's been formulated to be independent of the gastric pH, which is good. So if the patient does have alterations in their stomach acid, we can kind of bypass that by giving a suspension of this compound. It's got a long half-life, of course, with daily dosing. And of course, there's going to be hepatic biotransformation alterations because this is an azole compound, and you're going to see that effect on the CYP cytochrome P450 enzyme systems. Toxicities with itraconazole include GI upset, particularly with the suspension. You can see alterations in adrenal production of some of these steroid-backed hormones. You can see heart failure exacerbation. There is some negative inotropy on itraconazole, and we can also see some drug-induced hepatitis. And those hepatic-based drug-drug interactions are really quite prevalent. Okay. Itraconazole has been indicated for candida, aspergillus, and it's also been indicated for specific histo and blasto type fungal infections, as well as skin and nail infections of dermaphytes. Voriconazole is another group, or another drug in this group, with properties that are very similar to fluconazole. In terms of its both its oral and its IV formulation. This, however, is twice daily oral dosing. We see a wide volume of distribution. We see CNS and CSF penetrance. There's the cytochrome P450 enzyme system with specific drug-drug interactions listed here. Voriconazole is associated with a photosensitive type of side effect profile on the skin. We can see visual disturbances. They're usually mild, and they're often reversible. And again, we can see this kind of persistent theme of drug-induced hepatitis. Voriconazole has a broad spectrum of activity against many yeast and molds. I was looking at a British textbook. Let's spell molds American style. And it's really the treatment of choice for aspergillus. And so when you talk about aspergillus type of infections, voriconazole, that's your man. or your woman if it's a female, I'm not sure. And it's really not active against some of these other mucor and rhizopus type of fungal infections. Posaconazole is the last azole that's available. Here we see both IV and oral forms. You can see it in tablets and suspension. And it's ironically the tablets actually have better bioavailability than the suspension. Okay, the suspension requires gastric acid. You got to take with food, and in some cases a high-fat meal to alleviate some of the side effects. There's some CYP P450 drug interactions. The major side effects to posaconazole are GI upset, nausea, vomiting, diarrhea, stomach pain, and then this rare but persistent theme of hepatitis as a drug-induced outcome. Posaconazole is important because it's really got the broadest spectrum of activity through various different species and genera of bacteria, and it's indicated for both the prevention of invasive fungal infections in patients that are of high risk. And so patients that have bone marrow suppression or leukemia, HIV/AIDS, these are the ones that are at risk for invasive type of fungal infections. Okay. And so the last group of drugs are the echinocandins. Capsofungin is really kind of the main one. We'll discuss capsofungin here. The other ones are pretty similar. There's some different pharmacokinetic and pharmacodynamic differences between them, but they're all essentially the same. So I think for the ease of this lecture, we'll just focus on capsofungin. So echinocandins, how do they work? Well, they're going to block the fungal enzyme called glucan synthase. And remember, glucan is an important and critical cell wall component. And when you start messing with the cell wall here, the cells can become leaky, and that can lead to cell death. Okay, and there's 3 drugs, as I said before. We'll talk about capsofungin. They all basically have the same properties. Within the echinocandins, a lot of them are IV formulated only. There's very few that are orally administered. We can see long half-lives. We can see metabolism in situ, meaning that the biotransformation of this particular drug class occurs at the site of the fungal cell membrane. Okay. There is, however, no hepatic P450 enzyme alterations, and we don't need to reduce the dose in patients that have renal insufficiency, so that's pretty good. However, patients that have liver function alterations, particularly liver disease or cirrhosis or something, this drug actually might accumulate, and so you may have to be a little bit more careful in the liver patient than in the renal patient. The toxicity profile is actually quite low. The main side effect that's reported with echinocandins include this release of histamine, and that's particularly relevant during infusions of these drugs. So you can see like fevers, rashes, phlebitis. Anaphylaxis to this drug is quite rare, but it is reported in the literature. You can see alterations in potassium, as well as biliary enzymes as well, but those are, again, quite rare. You'll use capsofungin and echinocandins for a variety of candida infections, both of which are listed there, particularly when they're fluconazole resistant. You can use them also for refractory aspergillus infections, and there's some other clinical notes about what they are specific for and not listed here. And that's it. That's the last slide. So if you have any questions about antifungals, please email me, and we will continue on through the curriculum. Thank you.